Good afternoon. My name is Sharon Letchworth, and I'm the Program Manager for the Wake Forest Alzheimer's Disease Research Center, also known as the ADRC. This afternoon, we have another installment of our Alzheimer's 101 workshop series. The goals of our series are to guide the development of competitive research applications in Alzheimer's disease for internal pilot grants and development projects, as well as for external grant funding, to introduce researchers to the nomenclature and state-of-the-art in Alzheimer's disease research, and to provide insight into new directions in the field. Today's workshop will focus on cognitive assessments. We have three speakers this afternoon, Drs. Bonnie Sachs, Suzanne Kraft, and Steve Rapp. Dr. Sachs will focus on how cognitive assessments are conducted, what cognitive data tells us about Alzheimer's disease, how cognitive data are used in adjudicating participants, and Dr. Kraft will focus on cognitive composites used for Alzheimer's disease, while Dr. Rapp will focus on combining cognitive data with other types of data. Our first speaker will be Dr. Sachs, who is a board-certified clinical neuropsychologist with extensive background in neuropsychological assessment, cognitive aging, and neurodegenerative disease research. She currently co-leads the Wake Forest Alzheimer's Disease Research Clinical Neuropsychology Service along with Dr. Kraft. This includes adjudication of cognitive diagnoses for research participants. She also leads the adjudication panel for the multi-ethnic study of atherosclerosis, MESA-MIND substudy, and the SPRINT blood pressure intervention trial, SPRINT-MIND substudy, both of which are collaborative multi-site trials which include evaluating cognitive outcomes in older adults with vascular disease. As part of the ADRC Clinical Core, she helps lead the Clinical Harmonization and Implementation Service, which collaborates with numerous large multi-center studies through an innovative program that translates ADRC-based assessments to large cohorts. As part of the service, she was instrumental in the development of the UDS-3 telephone and video cognitive battery provided to other ADRCs during the COVID-19 hiatus that will become a valuable tool for future ADRC activities. And now I'll turn it over to Dr. Sachs.
All right, well, thank you for having me today at this Alzheimer's 101 workshop where we're going to discuss cognitive assessments. My name is Bonnie Sachs. I'm a board-certified clinical neuropsychologist, and I'm an associate professor in the departments of neurology and geriatrics, and I'm the neuropsychologist for our Wake Forest Alzheimer's Disease Research Center. So as many of you know, our Wake Forest Alzheimer's Disease Research Center was established here about 5 years ago. And our ADRC is part of a larger network of NIH-funded ADRCs, and you can see them on the map below. There are 31 ADRCs throughout the country. Here at Wake Forest and throughout all of these other ADRCs, there exists a clinical cohort of participants, and these include individuals who are healthy older adults and also those who have MCI or mild cognitive impairment and dementia. Our clinical core here at Wake Forest is about 500 or maybe a little bit more, 500 participants, and these participants are really deeply characterized. We use, all ADRCs rather, use what's called a UDS or a uniform data set, and we're currently on version 3 of the UDS. And the UDS is a group of shared or common data elements that are collected across all the ADRCs across the country. And this includes cognitive data or cognitive assessments, which we'll talk about today, but it also includes imaging metrics, laboratory tests, spinal taps, and so forth. And so what we have here at Wake Forest is a really deeply characterized, a very deeply phenotyped group of individuals across that cognitive spectrum. And the unique thing again about ADRCs is that all of the ADRCs across the country use these same common data elements. So these data that are collected across the country are ultimately able to be pooled to create one of the largest data sets of older adults and those with MCI and dementia. More than, I think there's more than 40,000 elements within this data set. So we really have a unique group of individuals here at Wake Forest, and this data again gets pooled so that individuals who are interested in using this for research will have access to a much larger and a much broader cohort of individuals who have, again, those same data elements. And as most of you know, Dr. Suzanne Kraft and Dr. Jeff Williamson are the primary investigators of our ADRC here at Wake Forest. Our clinical core, in addition to the cognitive data that we collect, they're deeply phenotyped in other ways that I believe Dr. Kraft or Dr. Rapp may talk about. But that cognitive assessment is a really key part that we use to phenotype this group of individuals that we have here. And I'll come back to this slide later, but this just gives a schematic of some of the data that's routinely collected here, how that data is used to ultimately move people through our clinical core and to, if appropriate, triage them to other studies. Okay, so what are cognitive assessments? As a neuropsychologist, this is my bread and butter, but I understand that there are folks today on the call who are from very different disciplines. And so I want to start from the ground up and give everybody a really thorough view of what we're assessing and what we're collecting here in the ADRC. Okay. So this schematic here really shows that cognitive function is a conglomerate of multiple different domains. So in essence, to boil it down, cognitive assessments assess various aspects of thinking skills. And the thing that really is the essence of cognitive assessment is that we use standardized and normed test instruments that tap these known cognitive domains. So by saying standardized, what I mean is that the tests that we use are administered in exactly the same way to each person across our center and across all of these other centers. And that helps to reduce the variance that's brought on by doing things in different ways at different places, and to really increase the likelihood that we're measuring our participants' true cognitive ability. And when I say normed, that means that the tests we use have been developed and validated, tested out on thousands of healthy individuals so that we know what a typical or an expected performance should be for an individual participant. Like, let's say an 80-year-old Caucasian man with a high school degree. We know what typical cognitive performance looks like by using these tests. So when we talk about cognitive assessment, there are multiple domains that we think of, and you can see them sort of illustrated here. If your background is not primarily in cognitive functioning, these aren't unidimensional constructs. So we say, participants with dementia have trouble with memory, for instance, but that's what really makes cognitive functioning, in my opinion, so interesting and complex, is that each of these are much deeper than that. So for instance, you may have heard the term executive functioning. That really encompasses lots and lots of different skills and abilities. So, maintaining concentration in the face of distraction is an executive skill. Self-monitoring, shifting your attention back and forth between two things, and so on. Language, for instance, we think about language, we're talking right now, you're hearing me. That's all part of language, but it also includes other abilities like reading and writing and comprehension and coming up with names and words. And the same goes for memory, which is germane to our talk about Alzheimer's and dementia. We use this term a lot and we talk about memory a lot, but really this is a complex entity and there's different components of it. So learning new information is one part of memory. Encoding or solidifying it into memory is another part. And then being able to pull out that memory at a later time is yet another piece. So all of these pieces and parts go together to, allow us to function adequately in our day-to-day activities, like driving or managing our finances or attending school or work. And that's each individual cognitive function is very important, and also the outcome of daily functioning is important, because as I'll talk about in a minute, these are really key metrics in the assessment of abnormal cognitive functioning that we see, for instance, in dementia. Okay, so how are they conducted? So for those of you, again, maybe not in a clinical field or not in, in medicine or in psychology, this is sort of what cognitive assessment might look like. These are just some pictures that I found literally on the internet, but these give you a pretty good sense of what you might expect if you were a fly on the wall. So you can see here in the middle is an older adult, and she's doing what's called a clock drawing test. And for those of you who are clinicians, you're probably familiar with this. But a test like this might assess different aspects of cognitive functioning all in one measure. So it might assess executive functioning, her ability to plan or her ability to organize. It might assess spatial functioning, her ability to put things in the proper location. On the lower, I guess that would be probably the lower right, it looks like is that right picture. This participant is seeing a list of words, and she may be asked to recall them later on, assessing her memory, encoding and retrieval. In the upper left corner, I believe the picture, she's doing a task where she's copying a drawing, and that may assess again, maybe planning skills, or it could assess spatial or visuo-constructional skills. And then finally, in this lower left-hand picture is a task assessing, again, planning and organization and problem solving. So the tests that we use in the ADRC and in cognitive assessment by and large are paper and pencil-based tests. They're administered one-on-one. They can occasionally be computerized, but this is a pretty good snapshot of what this would look like if you were, again, a fly on the wall during one of our ADRC assessments. Okay, so this is us doing assessments nowadays. I can see that picture pretty clearly, but I'm kidding. This is more what our assessment looks like in the days of COVID. We are still collecting data on our research participants, maintaining the relationship with them, and ongoing data collection has been very important. And so while we do have the option, as Sharon mentioned, to do telephone or video-based assessments, we are still collecting some data in person, and we're taking appropriate precautions for our participants and for our staff. And you can see here she's doing another task that looks like it assesses maybe visuospatial abilities. Okay, so earlier, I talked about the common data elements, that UDS, uniform data set, which is the data that we collect here at our ADRC and at ADRCs throughout the country. And this just gives you a snapshot. I won't get into the nitty-gritty details about these tests, but as Sharon mentioned, we're happy to field questions or such if you have those. But when we think about the cognitive domains I mentioned, the MoCA, the Montreal Cognitive Assessment, you all may have heard about it in the news or in your work, is an assessment, a brief assessment of global cognitive functioning. It gives you just kind of a quick score, and you get a little sampling of all those different cognitive domains I mentioned. So if you're looking for just sort of a nice, quick and easy number to give you a sense of somebody's general cognitive functioning, this is a screener that we use that's part of the UDS. As you might expect, we also assess memory functioning quite thoroughly here. We have tests of visual memory. So again, seeing a picture or an item and then having to remember it later on. And we have tests of verbal learning and memory. So we have a story learning task and we have a list learning task. And what these might feel like or look like for those of you that are not familiar, the story task is where the cognitive tester would present a short paragraph to you auditorily, and then you would have to recall that immediately and then later on. And the verbal Ray AVLT list is similar, except it's a list of words that are presented and you have to recall them immediately and then later on. So that allows us to get at all those different components of memory that I mentioned with these different tests. All right, the tests in the next sort of darker shaded area are tests measuring attention and executive functioning. Now remember, I said these are complex and varied domains, and so we have some tests that get at different aspects of that. So working memory, the ability to hold something in your mind for a period of time, shifting your attention between different tasks back and forth, you know, working quickly on a task without getting distracted. These are all those components of executive functioning that I mentioned. These next three tests assess different aspects of language, so naming and then coming up with words quickly to specific prompts. And then we also have a measure of depression. You know, and again, I'll talk a little bit more about what dementia sort of is and how these tests are relevant, but participants who have significant depression may show some cognitive findings on tests that we use. And so most studies, including the ADRCs, have a measure of depression that's routinely given. So if you have questions about the intersection of depression and cognition, we may well have data to help answer that. Okay, so I will come back to this and talk a little bit more about it, but the question is sort of how do we make sense of it once we get it all, right? We have all these tests that are administered in a very standardized fashion. You know, if we get very objective data, and in the end we get a big pile of papers and then we get some numbers, okay? And again, I'll come back to this and talk about it, but the analogy that I want to draw is I think that these tests and these numbers and this panel of data that we end up is a little bit like a physician ending up with a panel of lab results after they've drawn blood. And the analogy that I want to draw is that, you know, a physician uses not only some of those cut points that are known, that are kind of built into the lab system, you know, okay, your glucose is above X, so that's too high, but they also use their clinical experience and they use their knowledge of that person to help them interpret it. So for instance, you know, one abnormal lab value might be clinically significant or it could be irrelevant. A lab might be slightly low, but in that clinician's judgment, you know, maybe that's not a sign of a pathological process. You know, or maybe it's, you know, one lab is low and then these other two are high, and it's really that combination of findings that make the clinician concerned that there is something, you know, sinister or something negative happening with that patient. And so really, we are looking for a pattern of abnormalities in all these test scores that give us an indication of what may be happening with our participant. So again, I'll come back to that a little bit, but I just sort of wanted to follow the process through from, you know, what are the cognitive domains that we're assessing? How do we assess them? What does that look like? And then sort of what do we end up with at the tail end of that? Okay, so this is sort of a little bit of a recap of what I said. The cognitive test patterns and scores help us infer underlying dysfunction or intact function of brain regions. And it's this pattern of dysfunction that's useful in identifying whether our research participants' symptoms, you know, their complaints are consistent with normal aging, with maybe under a degenerative disease, or with something else entirely. Okay, just a quick caveat. I use that example of a clinician looking at lab results, and I think that that's a fair analogy, but I did want to make a point that these are research assessments, and so we again do use that standardized battery of tests. The tests that we use aren't specifically selected for our participants that come in, so they're not a substitute for a clinical diagnosis. But we do feel within the ADRC that the tests that we have and the methods that we use are very appropriate for providing a research diagnostic classification. Okay. So what does all this data and what do all these tests tell us about aging and Alzheimer's disease? When we're thinking about cognitive function as it relates to Alzheimer's disease, I think it's important to set the stage and to talk briefly about the normal aging process first. in the past, in the early 1900s, the lifespan was quite short, and individuals who lived into their 60s or 70s often had multiple medical issues and comorbidities, and may have had a high burden of cognitive dysfunction. And so at that time, the belief was held that as you got old, you became senile. And for those of you who are clinicians on the call, you may have older adult participants or patients who say, oh, well, that was just my grandma had senility, or something to that effect. We don't hold that belief anymore. We know that many older adults maintain good cognitive functioning late in life. And we know that well-learned information and well-practiced skills remain relatively stable until very late in life. So things like vocabulary knowledge, memory for facts, or autobiographical memories, things like a memory of a birthday party or your wedding. Those things remain intact for very, very late in life. But what we do know is that there are some specific cognitive abilities that do change into later life. So things like working memory, mental flexibility, and some aspect of learning and making new memories. And I know, at least I'm on the downside of that processing speed curve. That's one of the things that changes most consistently throughout the lifespan and starts earliest. Okay, so given that there are real bona fide cognitive changes that happen in late life, and there are also cognitive changes that happen in dementia and MCI, the question is then, how do we make heads or tails of an individual participant's complaints of, let's say losing their keys or forgetting names or, getting lost on occasion? How do we make heads or tails of that? And so some of you have seen, probably many of you have seen this graph before, but this really just sort of is a visual representation of what I was talking about on the last slide. So across the horizontal axis is years or time, and on the vertical axis is cognitive function. And we see that upper line, that dark line that occurs with normal aging. There are some changes and some decline in aspects of cognitive function as we get older. So in the same way that our hearing or our muscle tone or our eyes may change with age, again, we know that there is some cognitive change with age. However, you can see the lower dashed line has a very different trajectory, okay? And that represents abnormal cognitive aging. Those individuals, depending on where you look at the curve of that line, they may be very early in that process and may just have some complaints about memory. They may be further along and fall into this category of MCI or mild cognitive impairment, or they may have progressed even further along that line and may be having both cognitive and functional changes, which are classic for dementia. So really, what we're wondering is, when we see an individual research participant, where are they on this curve? Where are they on this graph? And that cognitive data will help us answer that question. And so I put up this next slide, and actually the next two slides, not because I want this to be a lecture on what is MCI, but because I want to point out the importance of objective cognitive testing in the appropriate application of these labels. So both MCI, and you can see here where I put the star, both MCI and dementia require objective evidence of impairment on one or more cognitive domains. Now, when we're talking about Alzheimer's disease, most often, not always, but most often we're talking about memory, at least early on, okay? So this next slide is again busy, and you don't have to kind of read it all, but again, I just want you to focus on the criteria for dementia, which again, dementia is just an umbrella term that's used to describe multiple areas of cognitive impairment that are significant enough that they affect that daily functioning we talked about early on, okay? So really, the key pieces of data that we are collecting with our cognitive assessments help us understand which point, where on these cognitive trajectories our research participants fall. Are there complaints of, some periodic word finding, typical for normal aging? Or are there complaints of word finding or losing the keys periodically? Do they deviate substantially from where we would expect them to be for normal aging? Maybe they fall in this range of MCI. Or again, maybe the participant who says, well, I just have, every now and again, I forget things on the grocery list. But, I do notice a change. Maybe when we look at that standardized objective testing, we see that they are actually, those complaints are representing a significant trouble with memory or language or executive functioning. So that is what the cognitive data help us understand. Okay, so this slide you saw earlier. I want to talk a little bit about how we use that data to, again, help us figure out where our research participants are with their functioning. So as I mentioned, the cognitive assessments are a key piece of the data that we collect here at our ADRC. What happens after that's collected is something called a consensus conference, or a cognitive adjudication, I think is how Sharon had it worded on the first slide. So the cognitive adjudication process that we use here at Wake Forest, again, is pretty similar to many ADRCs across the country. So if you are interested, or in the future you end up using some kind of pooled or collective data, most centers run this way. And that's because cognitive adjudication panels are really the gold standard in research protocols for making these diagnoses. The outcome of the adjudication panel, or the outcome of the adjudication of data, is decided by a panel of experts, and these experts have a knowledge about cognitive functioning and aging and neurodegenerative disease. And the outcomes, as I alluded to earlier, are really based on pattern analysis, which includes not only looking at psychometric or statistical thresholds that we use to help us decide if scores are intact or impaired, but we use that plus cognitive patterns of preserved skills and impaired skills, plus that clinical expertise and how those tests map on to certain regions of the brain or certain areas of functioning, of brain behavior relationships. And so, it would be really lovely to be able to say, well, if this score is low and this score is high, that means this person has X, Y, or Z condition. But we know very well, actually, that multiple studies have used a variety of different algorithms or classification schemes or computer-generated formulas to try to classify participants or patients. And by and large, the outcome is that those panels or those algorithms really don't quite capture everybody, because there's many, many nuances of the data and of participants' history and background that go into that. So those algorithms just don't quite capture everything that needs to be captured in that cognitive review. So this is our panel of experts here. We have a number of physicians and PAs and nurse practitioners in geriatrics who participate. We have two experts in behavioral or cognitive neurology, and then myself and Dr. Suzanne Kraft are the neuropsychologists who participate. And really, we all bring different areas of expertise and background to the panel, and we have complementary skill sets. And really, it's a meeting of the minds when we review this data. Okay, so just a brief summary, and I'm keeping my eye on the time here. Cognitive functioning is complex, and those of us who study this and work in this every day, our job is to understand all of these nuances. But I think the good news for folks who are wanting to collaborate or participate in projects with us here at the ADRC, or who have an interest in cognitive functioning, I think the good news is that the research assessments that we do really do provide a comprehensive snapshot or a picture of participants' cognitive status and their functional status. So we have really good and well characterized participants with this research battery that we do, in addition to the other aspects that of data that are collected within the center that I'm not going to talk about. Further, the adjudication that we conduct here, I feel results in a high level of confidence about our research classifications, again, of either normal cognition for age, mild cognitive impairment, or dementia. And that's extremely important because those research diagnoses and the individual test data or data points that we gather as part of our cognitive assessments are really the key metrics that are used in all studies of Alzheimer's disease or MCI. So we have all of that data here. We have a panel of experts who interpret that and make sense of it. And again, that all of that is really, really key for this type and level of research. Okay, I think that's my last slide there.
Okay. Thank you so much, Bonnie. That was a great introduction.
Sure.
We have a few minutes for questions. And so there were a couple in the chat. Jason Grayson asked, is the final outcome of adjudication, I believe, by majority or unanimous? And Suzanne replied, by majority, trying to get 7 clinicians to all agree on the same diagnosis. Good luck.
Yeah, oops, I realized my video, I guess you all couldn't see me anyway, see the slides. Yeah, so sometimes it's unanimous. I think those are the really clear-cut cases. I would say most of the time, you know, we end up taking, you know, sort of taking a vote and having to go with the majority rule. And, you know, I actually don't view that as a bad thing because, again, we all have different, slightly different experiences and we all have slightly different expertise. And so I don't find that strange or odd, or it doesn't make me feel less confident. And I actually think it's a good thing because we all don't just sort of go with the majority. We all have different opinions about things. And depending on the case, you know, it may be, you know, it may be majority, but, you know, every now and again, it's unanimous.
Bonnie, since this is a longitudinal study, do you ever have a situation where there's maybe a watch and wait approach to the adjudication? Maybe somebody's borderline and you decide to see what their next cognitive assessment looks like before making that decision?
Yeah, absolutely. And I kind of go back and think about the example about a clinician with a panel of labs. You know, part of what makes this interesting, but also complex, is that, you know, I would say mostly don't come up with sort of a slam dunk. Like everybody feels like, oh, this is super clear. You know, this is definitely, you know, X, Y, or Z. You know, that happens sometimes, but a lot of times the cases are gray and they're difficult and challenging. And so sometimes we feel concerned that we may be seeing an emerging dementia or an emerging cognitive impairment on the testing. For those individuals, it may be an issue of watch and wait. We may then rely alternatively on other data. You know, if we have neuroimaging data or if we have biomarker data, we may put that information together to help us gain confidence or clarity. But we certainly do sometimes feel somewhat unsure. But again, given that this is a longitudinal study, we often follow folks for many, many years. And so we get even a clearer picture, I think, of what may be happening with their cognition.
Great, thank you.
Yeah.
Our next question is, why is the MoCA preferred over the 3MS or the MMSE?
And actually, we can hold that. I'm going to address that directly in just a few minutes.
Okay.
But I do want to say, although if I'm understanding your question correctly, Sharon, we always make a decision at the time, and then we revisit the decision every year. And some of the most interesting cases are the ones where you know, our decision turns out to be wrong. But that, you know, that is something we have to do just because of the protocol that we're following.
So this is not the focus of our Alzheimer's 101, but it's something that is emerging in the adjudication practice, and that is using imaging biomarkers or other biomarkers to assist in the adjudication along with the cognitive data. Do you guys want to say a few words about that?
Yeah, Bonnie, why don't you tell them how we work, how we do that?
Yeah, sure.
Procedure we've sort of developed for trying to incorporate them.
Yeah, and I just want to add a point of clarification to your earlier question and to Suzanne's reply. Yes, we always do come up with a diagnosis in our consensus conference. And I think one sort of unique thing that we can do, one way we can leverage our data is, we're of course interested in identifying MCI earlier and earlier. How can we catch people before this sort of becomes a more significant problem? And so by looking retrospectively at data, maybe there was someone we felt very on the fence about 1 year, and then the next year we felt that they definitely, had cognitive impairment. We can always retrospectively look back at that data and, make good use of that to understand this sort of emerging pattern. With regard to the biomarker data, we do incorporate that, and we have a very rich panel of biomarkers that we're collecting, but we're interested in adjudicating per normal protocol, mainly relying on the cognitive data that we have. And so we adjudicate individuals based on their cognitive and clinical presentation first, and we arrive at a diagnosis. And then we look at our biomarker data that we have, whether it be amyloid or tau or MRI or whatnot, and then we use that to help inform sort of an additional diagnosis to see how or if those things are different, how the biomarkers inform and influence our decision making.
Yeah, and just to sort of amplify that, what we're trying to do, many of you may be aware of the National Institute of Aging Alzheimer's Association research framework. And that is supposed to guide diagnostic categorization of participants who then are going to go on and be studied. And that framework took the cognitive phenotype and separated it out from the biomarker categorization. And so people get diagnosed as in terms of their cognitive presentation, and then they get also diagnosed in terms of their biomarker profile. And our feeling was that if we were going to look at the cognitive data and then look at the imaging, for example, at the same time, we might be skewed because there is an element of subjectivity, sometimes not a small one, in this process. And if we're looking at somebody that's borderline cognitively and they've got a head full of amyloid, we're going to be much more likely to say that they have some cognitive impairment. So for that reason, we decided to do the cognition first, and then we bring we give them a cognitive diagnosis, then we bring the biomarker data in to assign a potential etiology.
Great, thank you for elaborating on that. We have two other questions. Hopefully we'll be able to go through these pretty quickly. If not, we can defer them to the discussion at the end. But the first one is to briefly speak on what you consider the normal versus abnormal thresholds for MoCA and MMSE scoring. They feel like the literature there is a little bit of ambiguity. And the second question is, during the adjudication process, do you also rely on imaging to make a consensus diagnosis, which I think we just touched on there.
You can punt on the first one, Bonnie, because I'll talk about that a little bit too, but it might be, just to be more explicit about how we use the imaging.
So it sounds like Suzanne's gonna answer the first one. I will say it's complicated, and some of the original literature, you're right, is a little bit ambiguous or not fully, doesn't fully characterize all of our population. We'll just kind of put it that way. And then the second question, I'm sorry, Sharon, was?
It says, during the adjudication process, do you also rely on imaging to make a consensus diagnosis?
Yeah, I think we talked a little bit about that. We do have imaging available, and I believe I guess they maybe structural imaging. We do have access to the structural imaging, but do we? Sorry, I'm having a moment here. Do we also hold on that until the second part, Suzanne? I can't remember. I know
we don't look at the MR or the PET until after we've made the cognitive diagnosis.
Yeah, and again, that goes back to the framework that Suzanne mentioned, where these sort of frameworks have diverged a little bit to sort of a cognitive and clinical impression, and then an impression that includes or is dependent on biomarkers. And one of the biomarkers is neurodegeneration, so that's evident on imaging.
Yeah, and Sam makes the point that we have CSF as well.
Mhm.
But and then the imaging that we use MRI to assign potential etiology or evidence of neurodegeneration, as well as vascular injury or anything else that's weird. And then for a growing number of participants, we do have amyloid PET and now have started tau PET. So again, quite a rich source. And we do use them to assign the etiology. An example might be, we might say somebody has dementia. And then when we look at their amyloid PET, they have no amyloid. So they have dementia, but it's due to a non-Alzheimer etiology.
Great. Thank you, everybody. Our next speaker is Dr. Suzanne Kraft. Dr. Kraft is a clinical neuropsychologist and is the founding director of the Wake Forest Alzheimer's Disease Research Center, which was established here in 2016 and is funded by the National Institute on Aging. She's also co-director of the Stick Center for Healthy Aging and Alzheimer's Prevention. Dr. Kraft's research program investigates the role of metabolic risk factors in the etiopathology of Alzheimer's disease and related disorders. She has led numerous clinical trials aimed at ameliorating insulin resistance as a potential therapeutic or prevention strategy for Alzheimer's disease. And most of these studies incorporate extensive cognitive test batteries. As director of the ADRC, she oversees the development of extensive innovative resources to foster leading research in Alzheimer's disease. Central to the ADRC is the clinical core, which oversees the Healthy Brain Study, an observational study on several cohorts of older adults with either mild cognitive impairment, Alzheimer's disease, or normal cognition. Study participants receive extensive cognitive testing, as well as genetic, metabolic, biomarker, and neuroimaging characterization and longitudinal follow-up on these endpoints. Taken together, this deep phenotyping of participants results in a rich set of data and biospecimens, which is shared with investigators here at Wake Forest and around the world. Dr. Kraft will be speaking with us today about cognitive composites used in Alzheimer's disease.
Thanks, Sharon. And thanks, Bonnie. Again, that was just an excellent review and introduction. And so, of course, as Bonnie made you aware, we use the cognitive testing for adjudication, but each of the individual cognitive tests can also be used as outcomes in research. And so my goal is to talk with you about an approach I think that's gaining more widespread utility in clinical research and in clinical trials recently, which is the combination of cognitive tests into composites. And we've already had several questions on the most commonly used composites, the Montreal Cognitive Assessment and the Mini-Mental State Exam. And the Mini-Mental is one that's, you know, I think dates back to the 40s, if I'm not mistaken. And so just as a principle, these scales take items from multiple cognitive domains. These two particular scales each include a few items that assess orientation, attention, executive function, memory, and language, and from those produce a single total score and an unweighted score. That means each item has contributes to the total score. And so there's been a lot of controversies, too strong discussion about the Mini-Mental and its utility. And it's absolutely got great utility in many situations. It is, however, very insensitive to changes in normal aging. And by that, I mean scores on the Mini-Mental for people who are truly healthy aging and don't have the kind of preclinical Alzheimer's or other pathology that Bonnie showed, where we see changes in amyloid and other brain pathology 10 to 15 years before symptoms occur. The mini mental changes extremely slowly in that cohort of folks. And so to use it as an outcome in a trial, to use it in any kind of interventional sense, it's going to be problematic. It is definitely, Bonnie alluded to these older studies in which the mini mental was used quite extensively, and even in current studies where studies to purportedly looking at aging, showing changes in the mini mental. And the thought now is that many of those studies, the changes are being driven by folks with either preclinical AD or with MCI that is not adequately detected or assessed for in these studies. So you can have a study of an aging cohort, you can see changes in the mini mental or relationships of the decline in the mini mental with let's say frailty would be a good example. And you can't be sure that you're actually studying aging per se. You may actually have undetected MCI or preclinical AD that's driving those results. So the MoCA is been now in several meta-analyses shown as much better than the MMSE for screening for MCI, probably because it includes a greater variety of types of items, and probably because it has more direct assessment of executive function and relatively better, although still not great, memory assessment. So for example, the mini mental exam, the part of it that tests memory is remembering 3 items. And this is a relatively simple test that somebody who has a high education or people are going to be able to do that until they're further along the impairment path. The MoCA, requires learning over 5 items and a longer delay. So it does seem to have better sensitivity. However, it's still not very useful in the very early stages of MCI or in looking at changes in normal aging. And the question before about cutoffs, the cutoffs, again, were developed for the most part in large cohorts where there was not adequate screening for MCI. And all of us who work with these patients, we've seen people who clearly have MCI, who have brain pathology, and their scores on both the mini mental and the MoCA are in what would be considered the normal range. So that's just an ongoing issue. Next slide. So in research where sensitivity is highly important, and in particular in studies where you're looking at the effects of interventions over briefer periods of time, such as within a year up to a couple of years, the field is turning much more towards other types of composites. And one type is a composite of a single cognitive domain, where you would take the average Z-score of several tests of that domain, and that gives you a more reliable measure. So an example might be you would combine Z-scores from story recall and list recall and visual memory all into a single memory domain. Or you would include tests of trails and fluency into an executive function domain. And these, as I said, are more sensitive and more reliable in many instances, and they're useful in particular for studies that have very targeted hypotheses. So if you want to look at the effect of an intervention on hippocampal volume or something like that, you might go with a memory composite as an outcome for that type of targeted question. And all of the tests that are given as part of the ADRC can be combined, you know, in either rational or sort of machine learning ways into single domain composites using the raw scores. Next slide. And probably even more popular, particularly in clinical trials, now are multi-domain composites that can be quite sensitive and detect reliable change in cognition, even in preclinical AD. So before there's really frank symptoms, you can see subclinical decline, which is very helpful for studies, particularly studies on prevention, where you're looking to prevent people from developing the full spectrum, the full syndrome of MCI or AD. And they also provide a greater range of scores, which, you know, as we know, if you have a really restricted range of scores, like, for example, you would have on the mini-mental, it can be hard to see relationships with other variables, such as biomarkers. So the composites provide a greater range of scores and a better ability to detect those kinds of relationships. They are approved by the FDA as primary outcomes for clinical trials. Several of them are approved in that way. We'll talk about which ones. And then other versions may combine both measures of cognition and function. And the reason for doing this is to increase sensitivity, particularly in impaired populations, but also by doing this, you can minimize a loss of power that you might have, for example, if you have co-primary outcomes, one functional, one clinical, one cognitive, you're going to have reduced power to test your primary outcome hypothesis. And the composites that combine function and cognition are best in MCI or early AD, where there is some loss of function expected. Again, in preclinical disease or normal aging, those functional changes happen much more slowly. Next slide. So here's some examples. In the preclinical space or in the aging world, a test that was developed a few years ago that's getting much more use now is the PAC, the preclinical Alzheimer's cognitive composite, and some versions of that have emerged. It was first designed for the anti-amyloid or A4 trial, which is a prevention trial in folks who have amyloid in their brains but are still cognitively normal. And it was designed using a sensitivity approach from several large databases, the ADNI, the Australian Imaging cohort, and the Alzheimer's Disease Consortium cohort. So 3 large cohorts were used to develop this composite, which includes the mini-mental, along with delayed story recall using the logical memory story recall, digit symbol, and the free and cued selective reminding test total recall. So those are the 4 components. There's a Z-score calculated for each test, which is then averaged. And more recently, several studies showing that you could get much better or significantly better sensitivity by adding category fluency, which provides a component of semantic memory that is turns out to be very sensitive to preclinical decline. So those of you may be familiar with studies showing that that changes in writing ability are one of the very early changes that happen. People start writing in more simplified and less semantically complex ways, and that happens very, very early before somebody's cognitively impaired. So at any rate, this has been added now to the PAC-5, particularly for preclinical studies. Next slide. And so here's an example. The criterion that was used to develop the PAC was tests that would differentiate between amyloid positive and amyloid negative adults, that all of whom are cognitively normal. And the reason for this, of course, that the amyloid positive adults are thought to be at the very earliest stages of Alzheimer's disease and will go on to develop Alzheimer's disease over time. And so, as you can see in panel A, those are the PAC scores on the y-axis and time on the x-axis. The blue line are normal adults who are amyloid negative, and red are adults who are amyloid positive. And you can see the clear separation that occurs, very soon. They're within a half a standard deviation within 2 to 3 years. So what this means is that you can look at an intervention and know that over just a 2 or 3 year time, you're going to be able to see if that intervention is successful at ameliorating that decline. And then on the right is just the individual trajectories for each of the components. Next slide. So here's an example of how the PAC changes over time in groups that are defined by different risk factors. So the top two panels are, again, by amyloid positivity status, with the upper blue lines being amyloid negative, the bottom red lines being amyloid positive, and the middle line, some hypothesized intervention. But the blue and the red lines are real data. So you can see, particularly in the ABLE study, this very systematic decline over time. And then if we look at a couple of other risk factors in the lower left, is looking at it by the clinical dementia rating over time, with the upper line being folks who remained CDR or clinical dementia rating of 0 or normal, and the lower line, those who progressed. And then on the right lower is a biological risk factor, ApoE, E4 allele carriage. Of course, we know E4 is a big risk factor for Alzheimer's, and you can see the E4 non-carriers remaining stable over time and the carriers declining. Next slide. And then one last use case, which I think is particularly interesting. This is looking at decline in cognitively normal adults who are amyloid positive, who have either high or low physical activity levels. And you can see that the adults, they both have equal levels of amyloid in their brain. But you can see that the group who has higher physical activity declines less over time than does the group who has lower physical activity. So that's just an example of how you might use this measure. And we do have PAC and PAC-5 for all of our ADRC participants. Oh gosh, so that was those are the means that you're seeing there. What is missing is they were violin plots for our participants, but you can see clearly the difference in score over time. And also to make the point that the PAC-5 is now turning out to be very useful, not just with preclinical AD, but also in MCI. It can detect change in MCI very sensitively. So it's a great measure to consider for any study where you're going to follow folks with MCI over time, or look at relationships between cognitive score and biomarker changes or levels. Okay, next one. So a similar composite developed by the ABLE, the Australian version of ADNI, is the ZOVIN. And they developed it to improve on the PAC in two ways. One, by adding a measure of executive function, which is a letter fluency. And they also eliminated the mini-mental. And this is an interesting principle, which I think folks who don't work in psychometrics don't always appreciate. But more is not always better. And because the mini-mental is so insensitive, it actually can make your composite worse at detecting relatively subtle impairments, which particularly applies to preclinical AD and normal aging. So what you're seeing in the bar plots, the dark bars are folks who are have some amyloid, and the lighter bars are folks who have a lot of amyloid. And so the PAC is the second set of bars over, and this is change over time. So definitely there's change, and the folks with a lot of amyloid are changing more. But what's interesting is if you take the MMSE out of the PAC, you actually see a larger degree of change. And they compare this to the ZOVIN, which the two are roughly comparable. So there's a recommendation to use the PAC without the MMSE if you're looking at preclinical and a very early disease. If you're looking to look at change to MCI or in dementia, to include the MMSE in the PAC. And next slide. And so for clinical trials, the most commonly used composite to date is the ADRC, which was the first composite approved by the FDA for intervention studies. It has 11 scales, totaling up to 90. Higher is worse. You can see the list of the scales below. The issues with it is that it's lengthy, and several of the subscales are unreliable. So for example, comprehension is a judgment by the rater rather than based on any objective correct or incorrect response. And so there's just issues with it that have made many folks not thrilled with using it, but it has had a lock on the FDA for a very, very long time, which thankfully seems to be loosening a little bit. And there are new variants that are intended to increase the sensitivity that are being used. And we do have ADAS-COG data available for several studies affiliated with the ADRC, several interventional studies. Next slide. So here are probably two of the most recent and widely used variants. And these are variants that include cognition and function. So the ADRC, or the Integrated Alzheimer's Disease Rating Scale, simply administers all of the ADAS-COG and activities of daily living scale. It is very sensitive in late MCI and AD. It does avoid the issue of co-primary outcomes, but it's long and has the issues related to the ADAS-COG that we just mentioned. A new and in many Circle's more preferred version was developed using sensitivity analyses, taking selected items from the ADAS-Cog, the mini-mental, and the clinical dementia rating scale. You can see the items listed on the right. It's much shorter. It does have better psychometric properties, and it seems to be very useful in MCI and AD. It would not be useful in healthy aging, just because there are, the functional components of it would not provide any variability. So to summarize, next slide. Composites may be more reliable because they incorporate different aspects of cognition or of a cognitive domain, and they may be more sensitive to change over time. The trade-off is that there's a lack of specificity if you have a hypothesis that is targeted around a specific cognitive domain, and you need to be careful about using them with the appropriate stage of disease. And one could also take our cognitive battery and the other tests that we give and develop your own composite. And that's certainly something, we could encourage and facilitate. And another subtlety to this is that it looks like you could substitute tests in the same domain for a different composite. So an example of that might be if you're putting the story recall into a composite, the PAC, which uses logical memory, you could substitute our ADRC story recall for that and still have a valid composite. So I think that there's ways of using our data to create these new composites. And this approach, I think we're also hoping we can use to harmonize different cohorts. For example, the ADRC, which has its own battery, and Pepper studies have their own battery, and we might be able to harmonize them by creating composites that contain similar domains, although the exact tests may be different. So I'll go ahead and stop there.
Thank you, Suzanne. That was a great presentation. We have time for maybe a question or two, but want to leave some sufficient time for our last speaker. I don't see anything posted in the chat yet, but if you have a question, feel free to enter it there. Give people a little bit of time. Well, Suzanne.
I see a question from Kate, I guess. What tests are approved for clinical trials besides the ADAS-Cog? So the ADCOM and the IADRS are both approved for clinical trials, and the PAC is approved for preclinical, for studies, prevention studies in preclinical populations. So those are the ones that are primarily used now.
Well, I would suggest we go ahead with Dr. Rapp's portion of the presentation, and then if there are any additional questions for on composite tests, then we can return to that at the end. So our final speaker is Dr. Steve Rapp. Dr. Rapp is a specialist in clinical geropsychology with specific training and expertise in the epidemiology of aging, cognitive aging, and cognitive disorders of later life, including Alzheimer's dementia. A major focus of his research has been to identify predictors and modifiers of the pre-dementia syndromes in dementia. As principal investigator of the observational extension of the Women's Health Initiative Memory Study, or WIMS, he is monitoring the cognitive functioning and incident dementia and mild cognitive impairment in the WIMS cohort. He led the cognitive and adjudication protocols for the systolic blood pressure intervention trial, or SPRINT, the Action for Health in Diabetes Look Ahead Mind study, Lifestyle Interventions in Independence for Elders, or LIFE study, and the Multi-Ethnic Study for Atherosclerosis Mind, or MESA Mind study. He was one of the principals who introduced cognitive measures to the MESA study and as co-lead of the Wake Forest ADRC MESA core, he worked with the MESA study to bring their vascularly well-phenotyped participants into the ADRC through the recently funded MESA ancillary studies. He will be speaking to us today about combining cognitive data with other data types.
Great, thank you. Let's see. Good to go. I want to thank everyone. Thanks for the opportunity to join this workshop. It's terrific. And a special thanks to Bonnie and Suzanne for a terrific couple of presentations that really set the context beautifully for what I want to do, which is to describe how cognitive data can be used with non-cognitive data. So one of my favorite quotes from this morning is that cognitive data and the biomarker data and adjudicated outcomes that you've heard about can be studied in relation to a vast array of predictors and sequelae. Today, I want to give you 3 examples of studies. They're not within the Alzheimer's Center, but they will give you a flavor for what you might be able to do with the data that we have in the Alzheimer's Center, as well as the data that are available here at Wake Forest in these other studies that you might use to develop pilot ideas and such. And so we have riches of cognitive data in the context of other studies here at Wake Forest for you to take advantage of. So I'm going to talk to you about 3 different recent publications of analyses from the Look Ahead study, SPRINT trial, and from the Women's Health Initiative memory study. First one I want to share with you is, and by the way, these are not selected because they're landmark necessarily. It's just they're recent and they really do a nice job, I think, of showing you how we've used cognitive data to answer interesting questions. This is a publication, Owen Carmichael led this one, but you can see I've highlighted in red the co-authors from Wake. This comes from the Look Ahead study. And this one's looking at long-term change in physiologic markers and cognitive performance in type 2 diabetes. For those of you who are not familiar with the Look Ahead trial, it was a randomized clinical trial comparing an intensive lifestyle intervention, primarily diet and physical activity designed for weight loss, and compared to a diabetes support and education control intervention. There were over 5,000 participants in Look Ahead. This analysis focuses on 1,089 who had 2 or 3 cognitive assessments through some ancillary studies that were developed after Look Ahead began. The Look Ahead participants had to have BMI greater than 25. They were 45 to 76 years of age at enrollment. And of course, they all had to have type 2 diabetes. In this analysis, the predictors or exposures were changes in body weight as a result of the intervention, changes in blood sugar control as a result of the intervention, and physical activity. These outcomes, some of them may look familiar. Again, this is the modified mini mental state. This is a learning task, the Ray auditory verbal learning. Digit symbol coding is a processing speed and executive function task. Trail making test B, executive function, and the Stroop color word test is also a test of executive. And then for the Look Ahead study, we developed a composite that included all of the tests. So in this particular analysis of the Look Ahead, what Carmichael et al. Showed was that there were greater improvement in blood sugar control was associated with better scores in verbal learning and memory. That is, the fasting glucose was, improvements in fasting glucose were associated with better verbal learning and better processing speed with a digit symbol. HbA1c, which is, as you know, a reflection of longer glucose control, was associated, that is, a greater improvement in hemoglobin A1C was associated with improved processing scores on the digit symbol, speed of processing scores. It was interesting that greater weight loss had mixed associations, some showing benefit, some showing harm. I won't go into the details here, but you can, if you're interested, you can look at this, look this reference up. And it was from sensitivity analyses, we showed that the benefit was strongest among folks who were overweight but not obese at baseline, and those who had a history of CVD at baseline, but not among those who did not have a history of CVD. So this is a nice example of how the cognitive test scores in a sub-cohort of the Look Ahead trial opened up some findings, and then also, particularly this, where we saw harm on some cognitive function, it opened up some other interesting questions. The SPRINT trial, the systolic blood pressure intervention trial, was a place where we also had a large battery of cognitive tests. And that trial was a randomized clinical trial comparing intensive blood pressure control to standard control in older adults, folks over 50, who of course were hypertensive. And the intensive blood pressure control was, the target was 120/80, and that was compared to less than 140/90 for the standard control group. So a sub-cohort of almost 3,000 participants in SPRINT had intensive, detailed cognitive assessment at every visit. The rest of the participants they only got that if they screened positive on a screener. So this analysis looks at this sub-cohort that had the full battery. In this full battery, you'll recognize now some of these tests, the MoCA, logical memory, HVLT is a list learning task, much like the AVLT, figural memory task, naming task, category fluency, digit symbol coding again, trail making test, digit span, and then a composite, an overall composite where representative subscales of these tests were included. So this is interesting because this analysis was very interesting. By the way, you can see the many co-authors that are here from Wake Forest, and some of them are on this call, I'm glad to see. This was very interesting because the main SPRINT trial results showed, which were the primary outcome in the SPRINT cognitive part, was whether or not intensive blood pressure control reduced the risk of dementia. Secondary analysis was whether it reduced the risk of mild cognitive impairment. And those results were published prior to this study. And it showed that, in fact, lower blood pressure, achieving a lower blood pressure, protected against incident MCI. We had an effect, non-significant effect on dementia, the primary outcome, same direction, almost the same magnitude, but it was not statistically significant, and hence we have right now underway a follow-up study where we're continuing to ascertain cases, but because it looked to us like it was a power issue, not enough cases of dementia, but plenty of cases of MCI. So anyway, MCI was a lower blood pressure group had a protective effect against MCI. However, in this analysis, that we found no. Number one, for this analysis, we had, that is the analysis of cognitive outcomes, not the adjudicated outcome, but the cognitive function outcomes. We defined a memory composite and a processing speed composite as our primary outcomes for this analysis. What we found was that there were no differences between the two treatment groups in the memory composite. There was a slight difference, slightly significant, a non-clinically meaningful difference favoring actually the standard control group. The processing speed was a little faster in the group that got standard blood pressure control. However, that difference was not clinically significant, and it was, but it was statistically significant. We had exploratory composites for executive function, language, and the overall composite that I described, and none of those showed a treatment effect difference. So what this study did, and the fact that we had these rich measures of various cognitive functions, it allowed us to go in after the reporting of these main important findings about the adjudicated outcome that was very encouraging, to see whether the effect was concentrated in one or more domains. And the conclusion we drew, of course, was the effect, while there, because we saw it in the NCI, which means that folks are indeed showing a different, that cognitive function is changing with treatment, favoring the intensive blood pressure control. However, it's not concentrated within one domain or another. So this was really interesting and opened up, again, rich discussion and subsequent analyses we're doing now. So it was a nice example of having a good battery of tests. The last example I want to show you about using other data comes from the Women's Health Initiative memory study, which has been going on for 25 years. It's ancillary to the larger Women's Health Initiative study. And WIMS was, the original WIMS trial was testing the question whether hormone therapy versus placebo protected against probable dementia. The results were published in the mid-2000s. We found that, in fact, it put women at greater risk. And then after the trial was over, the hormone therapy trial was over, we continued in several ancillary studies to do additional testing and observation. So the WISCA study, which is the basis for this analysis, we came in later and gave everybody an additional and comprehensive battery of neuropsychological tests for a period of 4.5 years. Every year they got a full extensive battery in addition to the WIMS battery. And there was also another ancillary study that allowed us to come in, and in 1,400 women, we got structural MRIs. And these women were participants in the WISCA trial, in the WISCA observational study. And then there was a second MRI, but that doesn't come into play in this study. So the WIMS participants were over 7,000. This particular analysis, though, looks at 998 of those who were in the MRI sub-study and in the WISCA sub-study, so that we'd have the rich battery of neurocognitive tests, as well as the MRI, which we needed as a biomarker. The ages of the women in this cohort were 73 and 87 years of age. And the predictors here were small particulate matter, less than 2.5 millimicrons. We collaborated with the group from Southern Cal, who really are experts in and leaders in looking at how pollution affects the brain and cognitive function. And they were able to, by knowing where women lived in their, where they were from and where they had been from earlier in life, they could estimate the pollution that they were exposed to. Cognitive outcomes for this study, since it's focused on episodic memory, it wasn't focused on general cognition, but episodic memory, was the California Verbal Learning Test, which we included in the WISCA battery. The biomarker, and the reason that the MRI group was important to have, was this is an index that Ramon Casanova here from Wake Forest developed, in which it's based on, again, the structural MRI, the regional gray matter atrophy pattern allowed the development of an AD similarity index or pattern. And so he developed it on the WIMS data and then validated it on the ADNI data, so that a higher score in this is a biomarker for risk for AD. So what this analysis did, what we wanted to do in this analysis was first to see whether exposure to particulate matter was related to greater decline in episodic memory. Then we wanted to know whether that was explained by this AD risk biomarker or not. And so what we found were that the long-term exposure to ambient pollutants, small particle matter, was associated with greater decline in episodic memory in the immediate recall. We did not see the same effect in delayed recall. So this, I just want to, as an aside, point out so that this is why the sensitivity and breadth of assessment of the cognitive functions that both Bonnie and Suzanne were describing is so important, because you could have within memory, as we did here, you could have a differential effect on different features of memory. And so it's important and really valuable when you have nice, detailed, and multi-dimensional assessment of different functions, as we have in the ADRC. We did find that let me get rid of, I have to move, I can't move it, I guess. That decline in episodic memory was partly explained by the Alzheimer's risk score, reflecting that indeed the pathway to the poorer immediate recall, suggesting that it was at least partly through the effect it had on the brain. Okay, on the brain in an AD specific pattern. Before I close, I want to use this as an example of the variety of questions and correlates and interesting analyses that one can think about. This comes just from the WIMS suite of studies. That is, the cognitive data, both adjudicated outcomes as well as the test data, have been used now over a number of years in a variety of different analyses. And you can see here that some relate to genetics, some of them relate to what I would call psychosocial environmental predictors or factors correlated with cognitive decline or cognitive impairment. Different ingestibles, from statins to low-fat diet to chocolate even, and other aspects to related to energy and as I say, the consumables and different things, lifestyle, different ways in which we conduct ourselves behaviorally, and as well as some methodological developments. The Alzheimer's disease similarity pattern index that Ramon Casanova developed, he developed using some of the WIMS data. There are machine learning studies that have been going on looking at predictions of cognitive impairment and decline, and a variety of other studies. But there are a rich array of questions that can be addressed if the data are there. And as you've heard in the first two talks, we have really rich data within the ADRC to help you and develop ideas and papers and ancillary studies and studies of your own. And this is a real quote that I like, curiosity, Walt Disney, this one, curiosity, it keeps us moving forward, exploring, experimenting, and opening new doors. And I hope and encourage everybody to use the rich resources we have here at Wake Forest, including the ADRC, to do that. Thank you.
Thanks so much, Steve. That was a really great talk. I see that we have a question in the chat. This is from Mina. She asks, she would like to know, what is the earliest time that we can repeat cognitive tests in a clinical trial, 4 or 6 weeks? And is there any learning effect that can influence the result? I understand that you change, for example, the words, but the format is the same.
That's a question that can go to any one of us. Bonnie, so that depends. I'll give a brief answer and then let Bonnie speak to that, or Suzanne more thoroughly. It depends on what you're trying to do. There are practice effects that we always have to deal with. That is, doing a task prepares the person to perform better on it the next time they see it. So the time between the first time you give it and the second time you give it matters. So there is not a predefined time, but it depends on the question you're asking, I think, and how serious practice effect is going to be in interference. And maybe Bonnie or Suzanne would like to elaborate.
Suzanne, I don't know if you maybe want to take this, as it's pretty
Sure.
specific.
I mean,
to
it's a great
clinical
question.
trials.
It's a great question. It's something we struggle with. I mean, that's what speaks to the issue of having a good placebo or control group, because there are absolutely practice effects. And if I'm sure you can't remember back to my slides perfectly, but you saw for the cognitively normal amyloid negative group, their lines going up over time. And one of the things we know is that normal people derive more benefit from practice than do folks with MCI. So, so practice effects are important to try to control for. And your point too, Mina, about not just the words, but what we would call the meta test factors, just having the experience of being tested and having the familiarity with the general type of tests can it make somebody perform better. In general, you see your practice effects most between the first and second testing. So one design that's used is what would be called a pre-baseline, where you give somebody the test before you give them the baseline testing, and then you test them again. And that's one thing you could do to get rid of that really immediate practice effect. But and as Steve said, it's variable. If you have, so you're giving somebody a drug that's supposed to, help their hippocampus immediately, you would be able to see an effect maybe immediately. so you design the interval in the test depending on what the intervention is and what you think the mechanism is that's going to drive change on that test.
Thank you.
Steve, I would just say thank you for sharing those examples of combining cognitive data with other types of data. And it really illustrates, especially your last graphic slide, just how broadly that can be done and the extent of potential that's out there. And one of the main reasons why we wanted to put on this Alzheimer's 101 is to help spark some ideas in our investigators here at Wake Forest for using Alzheimer's Disease Research Center cognitive data with endpoints that we're not currently doing. So a lot of our pilot studies have gone to fund projects that are looking at biomarkers from fields of research in cancer biology and biochemistry and many other departments that have been well developed by those groups, but are novel to us. So we would like to just continue to encourage people to do that and to think about novel ways of using our data and combining it with your test, your biomarkers, your skill set. And if there's anything we can do to help facilitate that, please let us know.
Yeah, and we've worked with a lot of investigators who, we can help them design the best the best type of data to get from the ADRC to answer the question that they will want with their marker. So I don't know if Gagan's still on, but I'll use him as an example. He's looking at exosomal markers from the hippocampus. We might say, let's look at the relationship between those markers and a memory test. because it's a very region-specific hypothesis. Jason Grayson is looking at immune characteristics that questions would be better answered by looking at people who progress from normal to MCI and seeing if the immune markers predict that. So we can, it's very enjoyable to hear what the investigators particular measures and what they're wanting to test, and for us to try to help them figure out what would be the best type of data to answer those questions.
Hi, everybody. This is Tim. I have a loaded question for our speakers. Are you aware, since we're talking about cognitive testing and some of the recent controversy that's happened with the NFL and the race-based norms, are you aware of any symposia that have been brought about around the idea of race-based norms, how they may actually benefit participants and how they may be embedding stereotypical and socioeconomic factors into them? Are you aware of any symposia going on, or is that something we should consider doing in the future?
I'll start, but I think, I'd like to hear Steve and Bonnie as well. No, I'm not aware of any symposia, but it is a really important question. And it goes a lot of different ways. So there are certain tests that differ, where the normative values differ according to ethnic or racial groups, or different educational or socioeconomic groups. And it can work to cause one to either overdiagnose a condition, in the case if the race-based norms are such, if you're not taking them into account, and a lower score might be normal for a certain socioeconomic or racial group. So on the other hand, it could introduce systemic biases that are very problematic. So it is really tough. I'd have to say as a field, we're struggling with it. Probably folks like Lisa Barnes at Rush and Jen Manley at Columbia have done the most work in this area. I think it's a topic that would be great to discuss, or to organize a meeting around, driven by folks like Lisa and Jen.
I agree.
And it would be great to reach out to them to see if they have any thoughts of doing that. Because I know we'd learn a lot. I know we would definitely learn a lot from that. But it's a difficult question. It's also because norms, because there aren't appropriate normative groups. Because, for example, if we're talking about a research norm, we haven't had adequate research representation by different ethnic and racial groups to really develop what would be a set of norms that one would feel very confident in. There's so many little subtleties to this that could be causing issues, and so yeah, I'll get you for this, Tim. Wait till the next talk you give. But I don't know, Steve, do you have any other insights about this?
No, I think you've said it all. It's always a conundrum. We don't have a good solution for the problem. I see it in adjudication meetings where we'll see scores from minority groups and we go, okay, well, can we trust these norms? Or sometimes you don't have norms for that particular group. It's a very difficult thing. And Tim, from MESA, where in the early studies on cognition in MESA, we were very reluctant to say anything about ethnic and racial differences in scores that were significantly different. You just had to be very, very careful about that. So it's an area ripe for discussion and resolution.
Yeah. And I mean, again, you could frame it either way. If somebody is underdiagnosed, they're not getting services they need or help. If they're overdiagnosed, they're getting a stigma and so it's very difficult. I would say there's no existing cohort that can provide what I would consider, unquestionably reliable, valid normative data. So I don't think we have that today for cognition, and something that's desperately needed.
Thanks for handling that loaded question. I think it's important, an important discussion.
It is. It's we're having that conversation earlier about, placing barriers to participation that allow one to have large representative groups. I think there are, really good people trying to tackle this. My hope is it will get better.
Mm-hmm. Great. Thanks.
Sure.
We're running over time a bit, but I think it was well worth it because we had a lot of great discussion and a lot of great questions. So thank you to everyone for hanging around to the very end. And if you have a question that occurs to you afterward, please feel free to reach out and we'll do our best to answer it for you. And I'd like to just take another opportunity to thank all of our speakers today for their wonderful presentations.
Great. Thank you. Thanks, everybody.
Thank you all.
Bye.
Thanks. Have a wonderful evening.
Yep.